Yeah, my name is Tebbutt. I'm a PhD basic scientist working at the University of British Columbia, and I'm Chief Scientific Officer for the Proof Center of Excellence. Well, I can give you an example maybe from both. Start with the hearts. So take heart transplantation, right? So you have getting a brand new heart from a donor is pretty much the end stage, right? If you don't have a new heart and you're undergoing heart failure, you'll die, unless you have an artificial heart or some other kind of a device, but ultimately you need a new heart from a donor. Now, what will happen, it's like you're putting in a heart from someone else, you're changing the immune system somewhat, your body will react against that, okay? And if just like it would against an infecting organism, if you like, right? And what will happen is that in some cases, despite many drugs that have been found to dampen down our immune systems when we get transplanted, the heart will reject, okay? So basically our bodies will reject this organ. So, and that can occur up to 30% of cases within the first year after transplant. So in order to diagnose whether this rejection is happening, it doesn't mean the patient will die, right? The rejection, because you just increase the dose of the drugs, right? And you have to be very careful with this drug dosage, because too many of these drugs can actually cause bad side effects as well, okay? So what you need to do is actually diagnose whether this person is rejecting or not, and then basically then you increase the therapeutic dose of the anti-rejection drugs in that person, but not in the person that's not rejecting. But in order to do that, currently we're restricted to various tests, and they're very invasive tests. So the biopsy, right? This, which basically you open up a tiny little hole in the carotid, and you basically put a tube down there through the arterial system and goes into the heart. And some jaws come out of this device, and they grab a piece of the heart tissue. This is the donor heart tissue. And it grabs a bit of the tissue, it comes back out, and then you take that tissue, you slice it up, and you put a tiny one of these slices onto a microscope slide, you stain it with various chemicals, and you give it to a pathologist. The pathologist will look for signs of rejection on that tissue section. And that will be the diagnosis of acute rejection or not, okay? But they have to have this procedure done on them 16 times in the first year after transplant, and it's very invasive. The patients hate it, and it means that the patients, they can't, if they live in more of a rural area, they have to, they basically have to come all the way to Vancouver or somewhere they can have this procedure done. So it's a very invasive, not only within the body, but invasive on their time and their family's time, their work time, and everything like that. And it's not without risks as well, medical risks. And but that's the gold standard of the diagnosis of rejection. So what a biomarker could do is that if there are molecules in the blood that sort of go up or down, that at the time of rejection or very close to the time of rejection, you can basically measure those molecules and then say, okay, well, we'll just do the blood test instead. And that can be done. You can get a finger prick blood test, and you just send it away, and they can look at the molecules in that, and hopefully that will reduce the need for these invasive procedures that are currently the gold standard. So that's the sort of an example for how a biomarker could be used in the healthcare system for hearts. There are a lot of advantages socioeconomically, right, to have a diagnostic test for, say, acute heart rejection compared to the biopsy, right, the gold standard. Obviously, as we said before, there's it's very expensive to have a biopsy, right? You have to have a whole team of highly skilled people looking after you when you come back to the hospital and you have this biopsy procedure. And again, you're doing 16 of these things, and it costs several $1,000s each time, right? So, in the first year after transplant, the costs to the healthcare system is tens of thousands of dollars for one patient to have these biopsy procedures. If you could replace some, if not all, of these biopsy events with a simple blood test, you can reduce it to, you know, just a few $1,000s or even less. And not only that, but you can also reduce the need for all this traveling and, you know, to a central mainline hospital. The transplant patient won't have to take time off work. Their families won't have to take time off work if they're working as well. So all of these more socio-economic benefits could accrue not just to the healthcare system, but also in the wider economics of our country.